galaxy of specialists in the audience. So it gave me a real booster of interacting with you and talking of you on hypertension. Now, if I have to ask the young postgraduates and fellows here, is hypertension that difficult that it needs a deliberation in such eminent audience? Probably you would say hypertension is a simple topic, and why should we waste 20 minutes or so in discussing about hypertension? But if I tell you that when I began my medical school in the 1980s, and my teacher was Professor Mishra, and he used to teach us hypertension, and believe me, the first few years were very difficult. Hypertension for us was not easy. And when I started my practice maybe in 89 or 90, and by default, the first prescription of my patient of high blood pressure was hypertension. And the husband of the patient got up to fight and quarrel with me. My friend, my wife does not have hypertension. She has normal tension, I do not give her tension. How do you say she has hypertension? I said no. By hypertension, what I am meaning is a high blood pressure. So over the next few minutes, we would be talking of, does hypertension need deliberation? When do we start treatment for hypertension, particularly in a newly diagnosed hypertension? And then what should be the first line of drug we have to use? Now we have n number of studies, guidelines, recommendations, and believe me, each recommendation which comes to you is more confusing, more harming, and puts you in a dilemma. And at times when a new study comes to you on the net, we get irritated that what new is coming. And believe me, over the next few minutes, I will convince you that it is your practical experience in clinical practice which is more important rather than the sad textbook studies. If I ask you, what is a normal blood pressure? Somebody would say 120, the others would say 130, and somebody would say 140. And believe me, all researchers in the field of hypertension are equally confused. When we talk of three eminent recommendations, you will see in the next slide, all of them have different recommendations. If I ask you, can we prevent hypertension if it is so disastrous? Every one of you would say, yes, hypertension can be prevented. But over the next few minutes, we will see that it was difficult earlier. From the 80s, there have been studies going on to prevent hypertension. Today, you can prevent hypertension from developing. What is the 24-hour control so important? We talk of a fall in blood pressure in the mid of the night. We talk of some relative of ours developing a high blood pressure at 4 a.m. in the morning and dying of a massive cerebrovascular accident. What is it? This is a non-dipper in hypertension, and really believe we can prevent these catastrophic events early in the morning hours. Is it a primary or essential hypertension, or is it a secondary hypertension? Not very difficult to diagnose, but needs a few minutes to deliberate on. And then of course, a resistant hypertension, going beyond drugs, going to devices, going to denervation of the renal artery, all that is available. And in the next few minutes, I will be talking of my research and publications which have a number around 50 in hypertension in different journals. I will not mention the details, but just pass a remark on that. If you have to ask blood pressure record, which is the best method available today, somebody would say office record. Go to a doctor's clinic and get a blood pressure check. But believe me, n number of times the doctor recording of blood pressure is higher than the blood pressure which is recorded at home. And this is what is called a wild code hypertension. The other problem is you give a drug, you control your blood pressure to 130 or 120, and then early in the morning or in the night, the blood pressure falls to 90. And what happens? This disastrous fall of blood pressure leads to cerebrovascular accidents, ischemia, infarcts, embolisms. So don't reduce your blood pressure very vigorously. Be careful, at times take help of other occasions or other instruments or other methodologies to treat or control. Recording blood pressure is not difficult, but just tell you, select the right cuff, the right posture, and the right environment to check blood pressure. The first blood pressure was recorded in a horse, and it was equally controversial and confusing. They managed to further rectify or improvise on this, and finally, about 100 years later, the blood pressure was recorded by a sphygmomanometer. And that was the time blood pressure came. But the father of hypertension, Kaplan, has said blood pressure recording is a clinical procedure of great importance, but is performed in the most of the sloppiest manner. Nobody is perfect in taking blood pressure, including me, including an expert who is in a hospital, and on different occasions he may do an error in recording blood pressure. We have to admit that. So white coat hypertension is hypertension in the clinic, and a hypertension arbitrarily derived, what we find is 140 and 90. But you would see that in the year 2013 came 3 major studies or recommendations, and all the 3 are having a different record or recommendation. Somebody say the optimal is 120, the other say it is 140, and the third recommendation says that 120 to 139 is pre-hypertension. What is the modality of treatment and recommendations is again equally controversial. A point which JNC Ed has said that atenolol or beta blocker is not a good drug is again to be argued upon for Indian population. Beta blockers in Indian populations continue to give relief and should be used. So the guidelines, better to have 120 or lower, or 80 or lower. But what between 120 and 139? We do not start treatment below 139. This is what is pre-hypertension. And mind you, we can prevent this pre-hypertension from progressing to hypertension if we see the trophies type, in which an ARB was used below 139, and in the follow-up, blood pressure did not develop. And similarly, like a glucose tolerance test or an exercise TMT, you can do an exercise BP test, which was done in 71 to 82. Patients were exercised, and those who developed a high blood pressure on exercise over the next 6 years developed hypertension. So this is something like a glucose tolerance test, which can be used for high-risk individuals to prevent hypertension. So friends, pre-hypertension has to be identified and prevented from developing into hypertension. Now what is really white coat hypertension? If you go to a doctor's clinic, you are a stress responder. You are high stress situation, or the doctor gives you some stress, your blood pressure rises. These patients, if you remove the stress, BP may not necessarily come to normal. These stress responders have to be identified. Again, a fall of blood pressure in the mid of the night has to be identified, because a fall excessively can lead to a cerebrovascular accident. All these patients would need a 24 hours blood pressure ambulatory record and identify if their blood pressure falls or does not fall in the mid of the night. If it does not fall from 2 a.m. to 6 a.m., they are non-dippers at high risk of myocardial infarction or CVA, and give a long-acting drug which adequately controls the blood pressure and prevents these episodes. Now, what is blood pressure really about? It is a very simple thing. It is a product of the cardiac output and the peripheral resistance, the heart rate and the stroke volume, the vasoconstrictors, the sympathomimetics, and the hypertrophy of the vascular wall which occurs with age. Why a particular person develops hypertension? Why somebody in the same family does not develop hypertension? Why a friend who is high risk will not develop an hypertension? These are patients which are known as essential hypertension. And the problem here is sodium homeostasis defect. A high sodium content should normally be excreted by the kidney. If this sodium is not excreted by the kidney, there is a rise of vascular volume. This rise of sodium and vascular volume leads to an activation of the renal angiotensin system. This causes vasoconstriction, supplemented by a catechol excess, and develops an hypertension. So if you are not drinking water regularly, if you are dehydrating yourself, you are depleting the intravascular volume. This will reduce the renal blood flow, and this would lead to an activation of the renin-angiotensin system. So a proper healthy diet or lifestyle with frequent volume or fluid intake would prevent an activation of this renin-angiotensin axis, and a fall of blood volume should be prevented. Now, what are other factors? If somebody says that my father and mother had hypertension, do I have the risk of developing hypertension? I say, well, wait. The other patient comes that my brother has hypertension, my sister has hypertension, but my father and mother did not have hypertension. Believe me, the possibility of developing hypertension as a genetic error is more in the siblings rather than a transdescendant from the father or mother. What does it mean? That the genetic component is not that important. It is the environmental component which is more important. And if we can play with this environment to our benefit, we can prevent hypertension from developing. Age is always there, but we can prevent vasoconstriction by preventing this bad sodium homeostatic effect. If you reduce your sodium intake in a hypertensive, you may reduce your blood pressure. But reducing your sodium content in a normotensive will not prevent hypertension. There is no point in preventing or not taking sodium in a normotensive because it will not prevent your hypertension. Now, obese patients again, because of the insulin resistance, the endothelial dysfunction, develop hypertension. Not to forget the environmental factor, hypertension has a relation to the intrauterine life. And this intrauterine life, if it has a low birth weight in the intrauterine life, you are predisposed for hypertension after 30 or 40 or 50 years. These are studies which have documented. So it goes back to the environment in the intrauterine life. And we can prevent this. You develop hypertension at the age of 30. But what happens at the age of 10 years? You have a genetic susceptibility, you have a bad environment, you do not follow a regular lifestyle, and you develop hypertension at the age of 30. So prevent this by a good lifestyle, because this is only the tip of the iceberg which you can prevent from developing. And endothelial dysfunction will promote developing of vascular diseases and hypertension, which will lead to n number of problems, beginning from thickening of the vessel wall to all the bad systems in the arteries. Identify this rise of blood pressure by doing a fundus examination as early as you diagnose or suspect hypertension, and you can pick up changes in the fundus very early in the course of hypertension. Developing changes in the brain vessels, infarctions, hemorrhages, ruptures is quite late, and that is only when there is an impairment of the cerebral autoregulation which is impaired upon. It is not in the early stages of hypertension. And then you develop bleeds and hemorrhages and LVH and diseases in the kidney and so on. So all target organ damage will appear quite late. Don't wait for that. Now, hypertension is a slow killer. It is a silent killer. So what happens really is symptoms go unnoticed, and they are hardly any. You get dizziness, weakness or breathlessness which are missed upon. So you have parameters, you have the left ventricular mass, you have the pulse pressure recordings, you have the renal microalbuminuria, you have the carotid femoral valve thickness, the intima thickness, and can identify high-risk patients who would progress to developing target organ damage. Now, what is the benefit really? Benefit is in all ways. It reduces infarct, it reduces stroke, it reduces renal failure. And traditionally, we were thinking of a diastolic blood pressure which was important, but now the era has come when we have to identify that treating a systolic blood pressure will produce more damage, or allowing it to do will produce. So don't ever ignore a systolic blood pressure, which is difficult to treat, difficult to control as compared to a diastolic blood pressure. And systolic produce more damage to the arterial wall rather than a diastolic. You would agree that here meeting goals for a systolic is very limited as compared to a diastolic blood pressure. So lower blood pressure is better, but to what extent? Somebody would say, why don't you reduce your systolic to 80, 90, 100? Or diastolic to 70 or 80? Mind you, a J curve was there, which was given away for some time, but has come again in the INVEST trial that reducing your systolic blood pressure below 110 or 115 may do harm more rather than the good. Similarly, reducing diastolic below 70 may still do harm because the coronary perfusion would suffer. So J curve hypothesis has come back in a strong way, and don't reduce your blood pressure very drastically, which has again been supported in the ACCORD trial. So friends, blood pressure is an easy disease, but only 1/3 of the patients are aware of it. It is a treatable condition, but only 1/3 are under treatment. It is a controllable condition, but only again 1/3 get actual treatment. So if you have hypertension, shoot at the moon. Try to control blood pressure, and at least you would partially modify the disease and prevent the complications and control. In Indian population, the control is very low. It is uncontrolled is 70%, and in diabetics 81%. So only about 20 to 30% are under control, and it is possible to control this blood pressure. Can I take 5 more minutes, or do I stop here? Okay. Essential hypertension is what is essential, but secondary hypertension is what we know. So if you have a hypertension in a young patient, if you have a flash pulmonary edema, if you have hypertension not controlled with drugs, then this is secondary hypertension. Believe me, you can have n number of causes again, easy to identify. If you have unprovoked hypokalemia, if you have weakness, cramps in the muscles and blood pressure, you are dealing with a case of aldosteronism. If you have buffalo hump, if you have obese, if you have style, you are dealing with a case of Cushing syndrome. If you have a renal bruit on examination, you are dealing with a case of renal artery stenosis. If the pulse are discrepant, if the tumults are weak, it is coarctation of the aorta. If it is episodic hypertension, you have normal tension on one day, suddenly you would have palpitation and hypertension, it is pheochromocytoma. So identify these rare causes, which are secondary causes, about 5 to 10%, which will give you very rich dividend if you can control these patients. Identification is easy by potassium examination, by vinyl mandelic acid, catecholamines, a peripheral Doppler, and so on. Renal artery stenosis would reduce the renal perfusion pressure, and this will increase the renin. And this renin will not be controlled by any other modality unless you do a renal angioplasty or you put in a stent in the renal artery. And unless you do that, a number of drugs will fail in a renal vascular hypertension. So friends, I would come to the conclusion by saying that treating a disease is easy, but preventing a disease is difficult. And superior doctors are those who try to prevent disease by lifestyle modifications, by tackling with the global risk scenario of hypertension, and not being tamed away with the recommendations or guidelines, but judicious following the guidelines will help you. There are a number of drugs which are available. In very brief, I'll tell you that all the drugs are not sufficient, and that is the reason they are from 90 onwards number of trials in different situations. So I would give you a very brief overview that beta blockers should be used if you have angina, coronary artery disease, arrhythmias. They should not be used if you have asthma, peripheral vessel disease, or AV dissociation. Diuretics should be used if there is peripheral vascular resistance which is high, if there is heart failure, if there is an elderly hypertensive with systolic hypertension. Don't use a diuretic unjudiciously in gout because it raises the uric acid, it raises the triglycerides, and also causes a rise of the blood sugar. Calcium channel blockers should be used in CAD. Debate has come that short-term dihydrochloric therapy should not be used because they increase the heart rate. Heart blocks, you should not use verapamil and diltiazem. Alpha blockers should be used in prostatism, but a point of concern is postural hypertension. ACE inhibitors should not be used in pregnancy. They should not be used in bilateral renal artery stenosis, and similar is the case for angiotensin receptor blockers. All said and done, you may have a situation where your blood pressure is not adequately controlled, and this is what is known as resistant hypertension. In resistant hypertension, you may at times would like to use modalities beyond this. And this is what is the study is all about. There is a device. We know that the carotid baroreceptors, if stimulated by blood pressure, would send a signal to the brain, and the brain would send a negative signal to the kidneys, to the peripheral vessels, and the heart. And if you can stimulate the carotids by a device which is under human experimentation, this device is implanted like a pacemaker, would stimulate the carotid baroreceptors, and you would see over the time, over months, the blood pressure gradually comes down. So there would be a situation when you have resistant hypertension and you may like to use this. The last point, that if the blood pressure is not controlled, rather than going in invasive modality, you can go for simple lectotomy, which is surgical, but now you have a renal artery denervation. The renal artery in the adventitia is supplied by the adventitia fibers. These fibers go to the brain and bring a negative impulse. So if you can ablate this by using radio frequency current, you can treat your hypertension if it is not controlled with medicines. So friends, over the course of years and experience, these are my data which I could contribute to today evening. Thank you so much for the patient hearing, and I would be happy to have comments from senior people and some questions if there are any to answer.
Tell me the treatment guideline of isolated systolic hypertension.
Pardon, sir?
Treatment of isolated systolic hypertension.
Yeah, there are 3 trials which have come up in isolated systolic hypertension. The foremost is the SPRINT trial, which is used chlorthalidone and diuretics. The other 2 trials are the SHOP and the SHEP trial. The STOP treatment, systolic treatment, optimum prevention of hypertension, and the SHEP trial. And all of them have shown that calcium antagonists, diuretics, are the ideal drugs for isolated systolic hypertension.
Suppose a general patient comes to you with 140/90 BP. Should we start treatment for hypertension? When should we start it? And how frequent monitoring should be done?
See, the JNC 7 and 8 said that 140 and 90, below this we should not start it. But the other 3 guidelines have said that above 120 needs interrogation. And this is what is pre-hypertension. So if we can have other risk factors, and if the patient is a diabetic, then there are 2 trials, the ACCORD trial and the EQPDS trial, which says that reduce your blood pressure to below 130 and 80. If the patient has no diabetes, then lifestyle modification, follow up every month, and if your blood pressure does not come to normal or your risk factors increase, then start treatment as a medical treatment.